Ma'am, dot 7 will start.
Okay, I'm ready.
So that's the flow is, I'll just welcome and hand it over to Dr. Sushant sir. Sushant sir will be introducing you. Then you
Okay.
start your session,
Madam.
and after your session, Dr. Sangeeta ma'am will have her session. After that, the panel discussion. Then you'll be there part of the panel, ma'am, as a one of the
Okay,
panelist.
fine.
Then we'll have a concluding remarks from Dr. Neeraj. Sorry, sir, Sushant sir, I cutting, sir. Okay.
No, I said I wished Madam good evening. Good evening,
Yeah,
Madam.
good evening. Good evening. Good morning for me, but good evening.
Oh, sorry, ma'am. From our side, it is good evening.
I know, I know, I know, I know.
Gansham sir, good evening, sir. Sir, your voice is not audible, sir.
Hi, good evening.
Good evening, sir.
Good
Hi,
evening,
Dr. Gansham.
Dr. Gansham.
Hi, Dr. Gansham. Good evening.
Hi, नीरज डॉक्टर कैसे हो? All well?
Hi, hi, Ganesham sir.
I was
Sir, dot 7 will start.
Meanwhile, Ganesham sir, would you like to share with us panel discussion slides? Maybe we can check it out. We still have a few minutes to go. Yeah.
Oh.
Yes, we can see your slides. Yeah, they're changing as well. Perfect. Thank you. Thank you, sir.
Hi, good evening, everyone, and thank you for joining this webinar. As this is our final session in the 2025 calendar events. So, behalf of AstraZeneca, I would like to convey my sincere appreciation to Dr. Deepak sir, Dr. Neeraj sir for their unwavering support for the educational program so far, whatever we were conducted in 2024 and 2025. And also, my heartfelt gratitude also goes to Dr. Sushant sir and Dr. Vivek sir for leading the entire webinar series in 2025 with their all coordinated, well planned, in great way. They have supported me and they also guided very well to me and extending their support. I'm really grateful to both Dr. Sushant sir and Dr. Vivek sir. So I would like to invite Dr. Sushant sir, who is a member of MPI, to set the context and take the event forward. Over to you, Dr. Sushant sir.
Thank you, Shrikant. Good evening, everyone, and a warm welcome to today's webinar on Power of Pathology, Leveraging HER2 Interpretation and Reporting for Superior Patient Outcome. It's a pleasure to have all of you here. HER2 has evolved from being a single biomarker in breast cancer to a dynamic therapeutic determinant across multiple tumor types. With expanding landscape of HER2 targeted therapies, especially in breast cancer, gastric colorectal cancer, and now even lung cancer, accurate, consistent, and clinically meaningful HER2 interpretation is critical. Pathologists today have become key collaborators in therapeutic decision making. The correct assessment of HER2 status can directly influence treatment eligibility, guide targeted therapy, and also significantly impact prognosis. This makes it essential for us to revisit how we evaluate HER2 by IHC or by Ish, understanding current guidelines, addressing pre-analytical analytical variables, and also appreciating how advances in digital pathology, AI-assisted image analysis, and decision support tools can enhance accuracy, particularly for ultra-low cases of HER2, where subtle distinctions matter. With this in mind, we will move to our expert faculty who will take us deeper into this critical aspects. In today's webinar, let us understand from our experts on the utilization of technology, accurate scoring, and latest updates on HER2 reporting across solid tumor. To start our meeting, let me invite Dr. Savitri Krishnamurthy. Dr. Savitri Krishnamurthy is a professor, Department of Pathology, MD Anderson Cancer Center, Houston, USA. She has received a medical degree from Medical College, Hospital, Calcutta, and has been in practice for more than 20 years. Dr. Savitri is an expert breast surgical pathologist and cytopathologist with an extensive experience in pathological evaluation of breast tissue. Dr. Krishnamurthy would be speaking on addressing the conundrums of HER2 ultra low interpretation. Over to you, Dr. Krishnamurthy. Please go ahead.
Good.
Madam, you can share your screen.
Yeah, well, I have shared already. Can you see it?
Yes, ma'am, we can see.
Okay, fine. Good evening, everybody, and thank you for the invitation. It's an honor to come and speak to you today about addressing the conundrum of HER2 ultra-low interpretation. I truly enjoy speaking to, I think, your audience, which I had done, I think, last year, as you may recall, and lots has changed in the course of 1 year. And I hope today's webinar will be very educational for all the participants. So let's get started. As we all know, HER2 as a biomarker in breast cancer is indeed one of the success stories of biomarkers. So when antibody-based therapy got started for HER2, the whole emphasis was on identifying positive cases of HER2 amplification with protein overexpression. So the testing for HER2 was essentially reported in a binary fashion because everybody was interested in identifying HER2 positive. So we divided clearly HER2 expression in breast cancers into HER2 negative, which included the ASCO-CAP HER2 0, indicating, no staining or faint or barely perceptible incomplete membrane staining in less than or equal to 10% of tumor cells, or the HER2 IHC 1 plus, which is like faint, barely perceptible, incomplete membrane staining in more than 10% of tumor cells. And the clear positive was when it is more than 10%, intense staining, complete membranous staining in the tumor cells. And the equivocal, we again tried using FISH to divide them into positive or negative. However, as it is in medicine, the results of clinical trials really dictates how we manage patients, how we as pathologists deliver the results to the clinicians to manage the patients and see whether they are eligible for all the optimal therapy. So with respect to breast cancer, all along, when the emphasis was only to identify HER2 positive breast cancer to make patients eligible for targeted therapy with things like Herceptin, came a completely new arena with the possibility of even doing something for patients with low levels of HER2 protein expression, what was clearly HER2 negative breast cancer. So what happened is the two seminal trials that completely changed the landscape. So in Destiny Breast 04, the patients who were selected in this trial were either hormone receptor positive or triple negative. And to start with, these patients had low levels of HER2 protein expression, mainly HER2 1 plus protein expression in the tumor cells. Patients could have received previous chemotherapy for their metastatic breast cancer. And actually, the patients were stratified based on different chemotherapy that was given in the metastatic setting. On the other hand, in Destiny 06, which was done after Destiny 04, the patients were hormone receptor positive, triple negative was not included, but now the bar was kind of extended to include not just HER2 low, but also HER2 ultra low, and which means, like, even some amount of protein expression, which was not enough to call as HER2 1 plus. That means some amount of protein expression with incomplete membrane staining in less than or equal to 10% of tumor cells. And in Destiny 06, patients did not receive any previous chemotherapy, and exploratory analysis was done on HER2 ultra low expression. So it is very interesting that in Destiny 04, 60 to 65% of the people were HER2 low. And in Destiny 06, we understood that what was HER2 zero could be further separated into HER2 null with no, protein expression or incomplete membrane staining, and HER2 ultra low with incomplete membrane staining in less than or equal to 10% of tumor cells, which comprised not a small percentage, 20 to 25% of the patients. So with the approval of Destiny 04 and 06, it became very clear that these patients who have low levels of HER2 protein expression, not just HER2 1 plus, but also people which is more than 0, less than 1 plus, what is now referred to as HER2 ultra low with incomplete membrane staining, faint or barely perceptible in less than or equal to 10% of tumor cells, became eligible for getting treated with antibody drug conjugates or TDXT or Enhertu. So now this completely changed the way pathologists started looking at HER2 reporting for breast cancer, because now you have to deliver to the oncologist. Yes, traditionally what we have been doing in helping in identifying HER2 positive breast cancer stays as such. Nothing has changed, right? Like, we want to see complete intense membrane staining in more than 10% of tumor cells to call it 3 plus, and when it is 2 plus with weak to moderate complete membrane staining in more than 10%, we do FISH and again divide it into positive or negative based on the FISH results. However, on the other hand, the HER2 1 plus does not change. What is referred to as HER2 low, incomplete, faint, barely perceptible membrane staining in more than 10% of tumor cells, that stays as HER2 low. But on the other hand, what was HER2 zero now gets stratified into HER2 null with no staining, that means stone zero is staining in the tumor cells, versus what is referred to as HER2 IHC more than 0, less than 1 plus as HER2 ultra low. Now, for the pathologist, there is also important information. How do you identify tumor cells with very low levels of protein expression? So, when you put the slide under the microscope, or even when you use digital kind of platform to look at your HER2 IHC immunostains, what is 3 plus can be easily recognized at 4x or 5x, very low magnification. It becomes very easy to see the strong, complete, intense membrane staining. And what is 2 plus? You see it under 10x, but you go to 20x, you know that, yeah, it is complete membranous, but intensity is kind of less. So you're going to call it 2 plus. However, for the 0 and for the ultra low and low, it is not enough to just do at like 10x or 20x. So you can barely see it at 10x, what is 1 plus, and then in the case of HER2 zero or ultra low, you barely see it at 20x, but you have to screen the slides very carefully at 40x to make the distinction between HER2 null, HER2 ultra low, and HER2 1 plus. That is an important message to the pathologist. It is more labor intensive to screen the slides at 40x, as all pathologists would know. So the differences in staining patterns and intensity between 0 and 1 plus are indeed very, very slight or subtle, right? So HER2 IHC 3 plus easily seen at like very low magnification of up to 5x, HER2 2 plus up to 20x, but for clearly seeing 1 plus, 0 and 0 null and ultra low, we have to go to the 40x magnification to make that good distinction. So this is a nice article in ESMO. The lead author is Dr. Wu, and it is a very interesting study talking like clearly illustrating the issues of identifying these very low levels of protein expression, particularly HER2 ultra low. That means you are trying to catch tumor cells, even one tumor cell with faint, barely perceptible incomplete membrane staining can be regarded as HER2 ultra low, right? So that is not a very small task. So what are the challenges? So in this publication, and which is published in ESMO Open, you can see that 36 pathologists from 4 centers they looked at microscopic visual assessment of HER2 IHC slides from 50 surgical tissue specimens, all stained for HER2. These were previously called as HER2 zero. So look at it. The consensus among the 36 pathologists aligned with the previous HER2 zero diagnosis was only 72%. And then when the HER2 IHC 0 was subcategorized as null and ultra low, the consistency amongst the pathologists dropped down to 54%. So what does that tell you? That it is very challenging to achieve this consistency amongst pathologists for optimal identification of HER2 ultra low. So the variability in distinguishing HER2 ultra low from HER2 null cases, how can you really kind of bring it to the minimum? So pathologists clearly have to see this faint staining at 40x, and also it is left to them how they scan through the slides at 40x to get these kind of very low levels of expression. And adding to this problem of how you identify rare cells with this kind of very weak staining, there are individual differences in color perception amongst pathologists, which is also an interesting aspect to add to the problem. And many times there is a confusion for people to see whether it is really a granular cytoplasmic staining or is there really some incomplete membrane staining. Or in other words, is it really non-specific or does it really matter for reporting? So you can see that they also show here that when you do like categorization of HER2 null versus ultra low, like the 4 categories, then what happened was in 48% of cases, they had very low level of agreement. And in 4% of cases, the discordance between people got reduced. But then when they started doing very low categories, then the agreement amongst people was a little better. But nevertheless, the message from this is that for HER2 null and HER2 ultra low, the consistency amongst pathologists is really something that we all should be worried about, right? It is only 54%. Now, there is another great report by Shami again in ESMO Open, where they demonstrate that the best protocol for identifying HER2 ultra low is what is shown here. It is using the HER2 4B5 antibody, the monoclonal antibody, which is the Roche antibody. And, they clearly show the steps. Now, note here, they also say what kind of, kit you should follow, how long you should put the primary So I think this is reported to be the optimal protocol. I'm not so sure how many places will be able to follow exactly this protocol in their practice for optimal identification of HER2 ultra low. One thing to keep in mind is, as I said, in that ESMO open study where 36 pathologists looked at 50 cases, what they clearly kind of saw that there was confusion, right, in saying what is artifact, what is real. So it is good to understand for pathologists what should clearly be kind of considered as artifacts. So what are those? Cytoplasmic blush in the tumor cells should not be considered as anything. That is an artifact. Now, granular stain clots, like see here, this kind of clumps of brown staining with some kind of possible looking little linear, should not be regarded as incomplete membrane staining. When there is crushing artifact of the tumor cells, one should disregard that area for coming to a conclusion. And in many cases, when there is cluster of tumor cells, this kind of non-specific basal staining should not be regarded as positive. Artifactual retraction of the tumor cells leading to this kind of linear basal staining should not be regarded as positive. And of course, all pathologists know that when there is DCIS in a tissue section, you should not really count any kind of expression in the tumor cells. There is another kind of strategy that people can follow. Nothing very new, but put in a very nice, novel way. They call it, this is from UK, published in Histopathology, the ICE protocol. ICE stands for intensity, completeness, and extent. It is the same thing. That means you see the intensity of staining. We all know that when we report HER2, we want to know whether it is faint, barely perceptible, is it weak to moderate, or is it very intense, right? That's how we categorize. Completeness, is it incomplete membranous staining or is it complete membranous staining? And of course, the extent, it is eyeballing, right? We approximately say, oh yeah, is it 10%? Is it like more than 10%? And of course, there is a lot of subjectivity in this, but this can give a nice kind of guideline in how you categorize. Like, see, in this strategy, you can clearly, they show you. Say, for instance, you take the case and you identify it at 40x and you see that the staining is very faint. First of all, it should not be an artifact. And then you kind of see whether it is really complete or whether it is incomplete. Now, complete with faint 40x is not very common at all. What is more common is the incomplete, very faint. If it is more than 10%, it is 1 plus, and if it is less than 10%, it is 0. But here, ultra low is not indicated in this publication. But if it is just stone 0 at 40x and faint, it becomes HER2 null. And if it is like little bit of staining, it becomes HER2 ultra low. So again, like look at here at 2x, 4x, if it is very strong, if it is complete or incomplete, they clearly show how you can report it. Nothing new, but it is a nice way of expressing it to the pathologist, right? As like a quick cheat sheet that you look at it and you want to use it for your reporting. So, in essence, what are good laboratory practices to identify optimal kind of HER2 ultra low that is there in the tumor cells? So, a couple of things, which I think all the pathologists know. It is just to reaffirm what people know. So, obviously, we score only the invasive tumor. In situ should be negated. And second is that, like, you have to consider only linear membrane staining, incomplete, or it could be occasionally weak, faint, barely perceptible, and complete, but it is usually incomplete. Cytoplasmic granular staining should not be considered. I spoke about the ICE strategy, which is the same thing, but showing you can keep this in front of you and see how you want to put it. But if in addition to all this, for the lab, what is very important is to have a range of, controls, the inbuilt, like when you put external control on your slide, instead of just using 0, 2 plus and 3 plus, which is what majority of the labs do. It is good to also include as controls these low levels like 0, ultra low, low, as well as 2 plus and 3 plus. I don't know how far it is feasible in all labs, but that is something that can be used to. And obviously, like, the staining and everything, the pre-analytic, analytic factors should be well controlled in all labs. But if after all this, a pathologist still has some issue, they can obviously consult their colleagues. So that is all we have right now. So in such a scenario, when everything has been manual in majority of the labs, pathologists reading the HER2 immunostain is under the microscope. Even if digital is used, they are still doing manual digital in interpretation, right? So now we bring into the scenario something that is very rapidly emerging in all walks of life, but particularly for us as pathologists, what is there? And today we'll hear a little bit about what is there for us in the sphere of HER2 immunostain interpretation. Now, before we talk about that, let's remind ourselves that it is not really artificial intelligence. It is better to perhaps call it augmented intelligence, right? Which represents the use of machine learning or deep learning as a tool to enhance rather than replace human healthcare provider. The American Medical Association reminds us that it is better to consider this evolving role of machine learning and deep learning as augmented intelligence, which the concept is based on studies that integrate machine learning and deep learning with human experts in a synergistic workflow that achieves higher performance than either alone. So obviously you're trying to enhance what humans can do, but you're not trying to replace what humans can do. So there is a synergistic partnership between what humans do with what the artificial intelligence provided by machine learning and deep learning does for us. So with that in mind, let's see what this kind of digital pathology and computational pathology can offer you in comparison to conventional histopathology. So what is then the workflow changes that has to happen if you want to bring up digital pathology and conventional pathology? On the top, you see you procure your biopsy or your surgical resection through different types of breast surgeries. Then you process that tissue. You have to follow, very importantly, the reduce the cold ischemic time. That means put the tissue, the representative tissue with the tumor in formalin as quickly, in buffered formalin, as quickly as possible. The current ASCO cap is within less than 1 hour. And then you process the tissue with optimal validated protocol in your lab. And then you put the tissue section, you cut the tissue, put it, stain it, again with validated protocol. And then you do your immunostain, all validated protocol, look under the microscope, and of course, do your manual scoring following the ASCO-CAP guidelines, and you report again following the ASCO-CAP guidelines. But if you had a digital pathology or computational pathology workflow, what would you do? You have all these steps are the stain, you get your tissue section with your HER2 immunostain, but you use a tissue scanner to procure whole slide images, and you can apply these algorithms to your whole slide image to finally spit out something that can be a decision support tool for the pathologist. So you are not just throwing an algorithm to say what the HER2 immunostain result should be, but you are basically aiding the pathologist in fine-tuning what they are seeing and coming to an agreement with the algorithm as to what should be the final report. So obviously, why is so computational pathology is actually adding a new layer of kind of change in the field. Image analysis for HER2 immunostain was all along available in the last 10 years. But the algorithms that these deep learning is providing is much, much better than the image analysis protocols that was already existent in the field. So this computational based image analysis is what we are talking about for HER2 immunostain. But to do that, you really need your digital whole slide image. So what do these things do? So the challenges that we have, particularly in the field of pathology, as you all know, it is a subjective problem, right? It is a subjectivity between pathologists that adds to the problem. So if you bring in computational pathology on your digital images, it can increase the confidence of test interpretation. It can reduce subjectivity amongst pathologists, and seeking a second opinion becomes very easy for the pathologist. You don't have to keep carrying your manual slides to different pathologists. And obviously, it solves the shortage of skilled pathology personnel available in many laboratories. Now, as you know, like digital pathology has several applications, starting from using for primary diagnosis. You don't need the microscope, and you can determine prognosis of the patients with several algorithms that are available. You can predict response to therapy. And if you look at it, the adoption rate for certain things is little variable. So look at here, if you are taking digital images for using in a multidisciplinary tumor board, and many people are using that, right? But on the other hand, for biomarker analysis with algorithms, you see the uptake is still very low because it's still very new. And in between, you see all these applications. So in today's world, I think, it is a very rapidly evolving field of digital pathology, which is completely taking the way, completely changing the way we are practicing pathology. And it is indeed one of the most revolutionary and very disruptive change that is happening in the field. So, but there are a lot of challenges. It is not just for the Indian environment. Even in United States, this year I took over as chair of the digital and computational pathology for the College of American Pathologists. I'm fully aware of what's going on in United States. The adoption rate is not like very, very high. So around 55% of people in United States have scanners and they are using it for different things. But for primary diagnosis, it is only around 15 to 20% of people are using. So scanners have been available for the last 10 years. And even my institution, all the research that I have done with AI and everything is possible because we have all that. But for standard of care, we don't use for primary diagnosis. And even in United States, very few people are using. So in Indian environment, availability of scanners in only around 10% of labs, availability of a platform neutral, that means platform agnostic. So, when you use algorithms, you have to keep in mind several things. What scanner are you using to get your whole slide image? What is the image management system that you are using to view the images? What kind of monitors you are using to view the images? All these has to be taken into consideration. So is there a validated computational algorithm that is kind of scanner agnostic, image management system agnostic, monitor agnostic? We really do not know. The most important thing, I have to point out to you, see the high cost for whole slide scanners, computational tool, digital storage space, paying for that. It's not just for Indian environment. In our survey here in United States, which is going to be published, it is a CAP survey, people cited high cost as the barrier to adoption of digital pathology. Last but not the least is limited awareness and acceptance. Amongst pathologists, some people embrace it, some people don't like it at all. In fact, here I see that some people after COVID, when digital pathology became more, people retired. They said they don't want to do pathology using digital images. So there is a reluctance to, and there is a fear that, everything is changing. It's very different from the way they were practicing. So people either are not aware or they have reluctance to accept. So in such an arena, if you have computational image analysis for HER2 IHC assessment, what is there for the pathologist? So I showed you, right? Like, the problem is the subjectivity and the lack of consistency. So these digital algorithms, the AI algorithms for HER2 immunostain interpretation can aid in consistent scoring and overcome the subjectivity in the interpretation for optimal, identification, particularly for HER2 at the lower end of spectrum. Now, when there are great drugs to treat the patients, it is our job as pathologists to deliver and tell the oncologist, who is low and ultra low so that they can be eligible. So the bottom line is distinction of HER2 null from HER2 low and ultra low. So whole slide images of HER2 immunostains are needed to apply this AI algorithm. Now, one of the issues is, I will talk in the next few slides, several AI models are available, but none of them are really approved for standard of care. So our own, here you see in literature, this is one of the early studies published in Modern Path is computational image analysis. But mind you, this is like using like a module attached to your computer for, putting an algorithm to your annotated area. It's really not whole slide image. But nevertheless, it's an early study that showed that particularly for 0 to 1 plus, you can improve the accuracy. Junior pathologists benefit from these kind of algorithms. And the impact of AI model, they also showed, was good in cases where there was heterogeneity in expression of the HER2. As you know, heterogeneity is much more prevalent at the lower end of the spectrum. So this virtual reality module attached to your microscope with applying an AI algorithm is very novel, but I don't know how much it is practical to come into the field. So this is a study that I am very proud of, and I participated. It is AI algorithm application study, 120 cases of HER2 IHCs, multiple labs with different, all using 4B5, some using another antibody, different scanners. This was tested. So, or in other words, the algorithm worked well across, scanners, across, different labs, across different monitors. And it had that, the usual standard of care distribution of HER2 0, 30%, HER2 1 plus 32%, HER2 2 plus 20%, and 3 plus 50%, which is the range of distribution in standard of care that we see. And it had like a two parallel arm with a crossover design. So what does that mean? That means there were 5 pathologists who served as I was one of the expert pathologists, as the ground truth. So their diagnosis was considered as the ground truth. Then 4 general surgical pathologists were asked to read these 120 slides with and without AI kind of aid, and their performance was compared with the ground truth performance of the expert pathologist. And very strict criteria were laid, as what was consensus was 4 of the 5 pathologists agreeing on the reporting of a given HER2 immunostain was considered as the standard. So interestingly, you see in this case, it became very clear that overall, if you took only 92%, 92 out of the 120 cases got a high level confidence, a ground truth diagnosis amongst at least 4 of the 5 pathologists. And if you took only those cases, the average agreement with the experts happened. With AI, it was 88%, and without AI, it was 85.3%. So obviously, these are standard practicing pathologists. They did pretty well. However, when you see the inter-observer agreement, very significantly, it kind of changed with 69.7% versus 77.2%. So you can see that with the application of AI algorithm, even for general surgical pathologists, you can get high inter-observer concordance and high agreement with the ground truthers who were all expert breast pathologists. And when the analysis was done with respect to the power of AI for helping the pathologists distinguish between 0 and 1 plus, they did very well. So you see here, the overall percent agreement changed from 69.8% to 87.4%. But the average agreement with the ground truthers only increased from 81.9% to 88.8%. So what does that tell you? Higher agreement with the ground truthers and higher inter-observer concordance can occur for pathologists if they used an AI algorithm, particularly for identification of HER2 at the lower end of the spectrum. Now, what is this algorithm? I think it is the Galen platform that was used. So it is very interesting that it identifies the invasive tumor, so there is no bias with the pathologist marking the region of interest. So you are removing that bias. So it identifies the invasive tumor, and then it annotates the staining. See, the different color codes is for the level of staining. See, in the corner, it will tell you when it is an faint staining, it is green. See these green circles? Blue is like stone zero staining. And then you have yellow is moderate complete staining, and intense is, of course, the very red dots. So clearly, in a given area of invasive tumor, it quantifies the level of staining. And at the top, it will tell you that this is a HER2 0. Because I think, at this point, even ultra low, you can clearly see it is saying 0. But then obviously, this is an ultra low case where 7.97% of the tumor cells show incomplete membranous staining. So this is an example of HER2 ultra low. But see here how wonderful it is. This is a linear linear membrane staining in the tumor cells, and how beautifully, see, this marked this as clearly with the green kind of circle. And again, here, see, this is another group, and it clearly shows that this is. So it makes it very easy for the pathologist to confirm and agree or disagree with the algorithm. Now, I find these kind of tools particularly valuable for surgical excisions where there is a bigger piece of tissue. Doing under 40x and trying to see an ultra low case takes a lot of time. But when you use these kind of algorithms, it clearly tells you what is the level of staining, right? So, see here, like, you're debating, what am I going to call it? Is there any 2+ in this case? And so on. But clearly, the algorithm points out that in this case, the faint membranous staining is still 7.75. It is still a HER2Z ultra low case because there is less than 10% of staining with incomplete membranous staining, very faint in the tumor cell. So, this kind of AI algorithms are fully automated solution for recognition of invasive tumor, and it is agnostic to any antibody that is used, and it can serve as a very robust ancillary aid. Now, we also did a HER2 early evidence program in 15 centers. Each center gave 150 to 200 slides, has 2 pathologists reading from each center with and without AI. This was presented in the San Antonio Breast Cancer Symposium in 2024. Look at here, the experts agreed only 73.9% of times. And when you look at the pathologists with AI and without AI, 26 pathologists, this is an international study, and clearly you can see the inter-observer agreement and the accuracy really improves significantly with AI in comparison to without AI. Now, also,
Madam,
yes,
ma'am, we have limited time, ma'am. I would
okay.
request you to take another 5 minutes.
Okay, I am nearly coming to an end. So this large study is reports multi-center validation of a fully automated AI solution. So that clearly shows that pathologists supported by AI show improvement in HER2 scoring, consistency, as evidenced by inter-reader agreement and accuracy overall. So these are great decision support tools for pathologists in routine clinical practice that enhances reproducibility and consistency of HER2 scoring. Now, I also want to point out that this is not the only study. So in ASCO in 2025, right, this year, MindPeak, another vendor that offers AI algorithm, they presented their study of 105 pathologists from 10 countries. It's a very interesting study where only 20 HER2 immunostain digital images were provided to the pathologists with training. And then they again showed that with AI, there is agreement of 76.3% without AI compared to 89.6%. And interestingly, they showed that AI reduced misclassification of HER2 low and ultra low as null in 25.5% of cases. So that is very interesting, I think. So what is it? So I sum up here for you. So these are not the only vendors. So the IBEX Galen or the the MindPeak is not the only. There are several vendors. And so the bottom line is that AI tool as decision support aid to pathologists for interpreting HER2 is very much evolving at a rapid pace. Several AI tools are currently available. There is, however, no report of comparative performance. And just watch out, we have a study like that. It will be presented in ASCO this year and also in AACR. So there is a need to compare the tool so that people know which one to kind of get. So availability of whole slide image is a requirement, right? Digital pathology is needed. So several studies are ongoing to compare these tools. Now, from the College of American Pathologists, I don't know how many of you had the chance to come or see. This time it was in the CAP meeting. We did show an AI innovation hub in Orlando where the CAP has put together like a playground where people can test these different AI algorithm for HER2 right in the meeting. And the same thing was presented in the digital pathology meeting. So I end up my talk with trying to emphasize that 60 to 75% of all lab errors occur in the pre-analytic phase, right? Specimen collection, cold ischemic time, putting it in formalin quickly, transporting it, and, processing correctly. So I think adherence to pre-analytic factors is very critical. And I think sample collection and putting it in formalin within like minimum of cold ischemic time is a key requisite to get optimal results. And of course, it should be a well-validated processing, staining, immunostaining platform. 4B5 antibody, the monoclonal antibody, is the recommended antibody for HER2 optimal evaluation. So the takeaways are accurate identification of HER2 ultra low is a prerequisite for patients to benefit from antibody drug conjugate therapy. Differentiating between HER2 null, ultra low, and HER2 IHC1 plus is very challenging. One can follow the I strategy and computational pathology to reduce subjectivity, but the bottom line is adherence to strict pre-analytic factors is critical. With that, I end my talk. Thank you very much. Looks like I took a little bit more time, but with that, I end my talk. And I think at the end, there is a session to take questions. Thank you very much, everybody.
Thank you very much, ma'am. Thank you very much for educating us on the accurate reporting of HER2 ultra low and highlighting the utilization of augmented intelligence, its advantages and limitations, and its application in regular oncopathology lab. In view of limitation of time, I would request participants to put in their questions in the question answer tab, which is available in the screen on the lower side. We will be taking questions at the end of the webinar if time permits. We will move to next talk of our webinar. I would like to invite our next speaker, Dr. Sangeeta Desai. Dr. Sangeeta Desai is a former professor and head of pathology at Tata Memorial Hospital, Mumbai. She leads the molecular pathology lab over there. She has played a key role in establishing the advanced molecular diagnostics for cancer, including FISH PCR and gene panels for solid tumors at Tata Memorial Hospital, Mumbai. She has traveled across the country and played crucial key role in building the capabilities of many pathologists in understanding the scoring and interpretation of HER2 low and ultra low in breast cancers. I would request Dr. Sangeeta Desai to go ahead with the talk.
Thank you, Dr. Sushant. Let me share the.
Yes, madam.
Yeah. Now, is
Please.
Dr. Savitri still?
Ma'am,
sharing?
ma'am, she stopped sharing the screen. Ma'am, your screen is visible, madam.
Okay. Are the slides visible?
Yes, ma'am.
Okay. Yeah. So my talk is on impact of reporting HER2 in breast cancer and other solid tumors as per CAP reporting templates. My slides are, yeah, they are moving. Can anyone confirm whether the slides are moving?
They are moving. The
Okay.
second slide is come, madam.
Okay, good. So HER2 alterations are frequent across multiple metastatic solid tumors. Now on the screen, you will see 4 spheres, blue in color with different shades. And the first one is IHC score 3+, next is 2+, then amplification and mutation. Now, as pathologists, we are more conversant with breast and gastric and gastroesophageal junction adenocarcinoma HER2 reporting. But you must appreciate here that there is biliary tract, bladder, and gynecologic cancers where you will see HER2 alterations, and not only in the form of score 3 or amplification, but HER2 mutations are also seen in biliary tract and lung cancer. So let me go ahead. So clinical practice guidelines recommend HER2 testing by IHC in multiple solid tumors, and CAP has also published reporting templates. So if you see, we already have been using CAP, ASCO CAP and ASCP ASCO CAP guidelines for breast and gastric respectively. And recently CAP updates were published in September 25 for gynec cancers. ISMO guidelines are existing for, again, breast, gastric, and for lung cancer. And NCCN guidelines are existing for almost all cancers, right from gastric, pancreatic, colorectal, bladder, all the cancers which are listed over here. So there is enough guidance available now. Coming to HER2 in breast cancer, actually Dr. Savitri has wonderfully covered the entire gamut of HER2 expression, but I would highlight certain points like these are some historical aspects that pre-2007 we were the cutoff was around 10%, then the clinicians or oncologists got worried about high false positive rate. It was raised to 30%. In 2013, again, we had the change of cutoff, and all this was this evolution of guidelines. It was based on the evidence, level 1 evidence, which was arising out of clinical data. Currently, we have been using 2018 guidelines where it was highlighted that there are 5 HER2 interpretation, 5 HER2 groups. And we are also using ISH as well as IHC to report HER2 status. And 2019 onwards, there have been country-specific guidelines like Germany, France, and even UK published guidelines. And then ASCO published in 2023, followed by CAP published in 2025 June. And I'll be highlighting on those updates. And most important point is, once upon a time, we were only worried about dichotomous reporting or binary reporting of positive and negative. And now we have started appreciating continuum of HER2 expression. And so there is a spectrum of HER2 expression. Now, this was again beautifully described by Dr. Savitri, Destiny Breast 06 and 04 and 06 trials, and eligibility to use TDXD, that is antibody drug conjugate. And here you can, and this will be again highlighted by Dr. Ganesham, I'm sure. Now, if you see this in Destiny 04, HER2 low population was 60 to 65%. And by adding HER2 ultra low, the eligibility was expanded to almost 85 to 90%. And this expanded eligibility for the new drug actually extrapolated to updates in ASCO in 2023 and CAP in 2025. And now it is so important to denote HER2 low and HER2 ultra low breast cancer to treating oncologists. And so this is a familiar slide where from binary reporting, we are now appreciating the entire spectrum of HER2 expression. And actually, it is before 2022, HER2 negative breast cancer was actually undruggable. And now it is not only druggable, but it has become unstoppable with the recognition of HER2 ultra low. And Dr. Savitri has already alluded to how for interpretation, if you compare score 3, you can interpret it on under 4x or 10x. But as you come to lower expression, that is 1 plus 0, you have to go, the pathologist has to change from 4x to 10x to 20x to 40x and use ICE criteria, that is intensity, completeness of staining, and extent of staining. And so now we have to recognize HER2 null, HER2 ultra low or 0 plus, HER2 low, and HER2 positive. So this is the latest ASCO guideline 2023. You must remember that HER2 low is not considered a separate biologic category, but it is a biomarker. And 2023 ASCO guideline did not even differentiate between HER2 null versus HER2 ultra low. And but it is advising us to include a footnote in pathology reports. So what does this footnote say? The first two lines are about HER2 positive and how HER2 is actionable target. And then it talks about HER2 low breast cancer definition, that is 1 plus or 2 plus non-amplified. So these are basically, this is HER2 which is non-amplified, non-overexpressed level, and which is amenable to treatment by cytotoxic drug delivery. And here HER2 is acting as a vehicle, and but it is necessary, and we must appreciate that there is no change in basic categories. So semi-quantitative IHC score should be included. And then the example is given below, that is HER2 negative for protein overexpression, 1 plus staining present. So that should be the report by the pathologist, so that everyone understands what pathologist is seeing under the microscope. Similarly, this is the CAP reporting template, which was introduced in March 2025, and it introduces HER2 ultra low breast cancer, that is 0 plus staining, and that is incomplete, faint, barely perceptible in less than or equal to 10% of tumor cells. And so there 0 is now 2 categories, or HER2 and this is still HER2 negative. And so in HER2 negative, we have 0 and 0 plus, 2 groups. So coming to the report per se, the reporting elements should be discrete scores, then percentage of sustain, intensity of staining, ASCO update footnote, CAP template. And CAP template is optional, and HER2 in situ hybridization status. And ASCO footnote I have already explained. Analytical elements like which assay, validation details, performance of controls, pre-analytical factors to be mentioned. And CAP template, the optional note is about HER2 low, HER2 ultra low, and Destiny 04 and Destiny 06 trial, and the fact that HER2 ultra low is amenable to TDXD. So HER2 0 plus with membrane staining is, which is introduced in CAP reporting template, is now in NCCN guideline version 4, 2025. And these patients, that is hormone receptor positive, HER2 negative, breast cancer, locally advanced or with visceral crisis or endocrine refractory tumors, should be treated with TDXD. So coming to HER2 in other solid tumors, so HER2 3 plus and 2 plus ISH, that is HER2 positive tumors, is targetable in gastric cancer with TDXD after the approval of Destiny Gastric 0102 trials. So this is what I said, HER2 has become now, is becoming tumor agnostic and unstoppable. And Destiny Gastric 0102 studies demonstrated a statistically significant improvement in response rate with TDXD compared to chemotherapy among patients with HER2 positive advanced gastric and GEJ, that is gastroesophageal junction adenocarcinoma. And CAP reporting template is to be used here is for gastric cancer, and that is gastric cancer specific criteria. Now that this is different from what we use in breast, because there are separate points for surgical specimen and separate criteria for biopsy specimen. And of course, completeness of the staining, because in gastric we accept complete basolateral and lateral staining as also as positive staining. Coming to pan tumor trial, that is DPT-02 trial. Now this trial included endometrial, cervical, so gynec cancers, as well as bladder and pancreas and biliary tract cancers. And here, HER2 IC score was used in the trial, and again, the drug was TDXT. And you can appreciate here that if you see overall response rate for all patients was 37.1%, but if you concentrate on score 3 ISC, it was 61.3, and mean duration of response for all patients, it was 11.3, and for wherever there was ISC score 3 plus result, it was 22.1 months. So greatest benefit was observed for the IC 3 plus population with antibody drug conjugate treatment. This is pan tumor trial. And so are there any guidelines for solid tumors for HER2 reporting beyond breast and gastric cancers? The answer is yes. NCCN recommends TDXT for multiple solid tumors based on Destiny trials. There are a number of these trials, that is pan tumor trial, gastric trial, colorectal trial, lung trial. And these Destiny trials have used gastric cancer specific HER2 scoring guidelines to identify patients eligible for TDXT. And here, if you see for gynec cancer, the result can be 3 plus or 2 plus. For bladder cancer, biliary tract, and lung cancer, it is 3 plus. For pancreatic cancer, it is 3 plus and 2 plus with FISH amplified. And rectal and colonic cancer, again, IHC 3 plus. So coming to CAP reporting template for HER2 in gynec cancers, this was recently updated in September 2025. Most important point is we have to use gastric cancer HER2 criteria while using dealing with gynec cancers. So this I wanted to highlight, and it is not breast specific criteria, but gastric cancer criteria, which we have to use for pan tumors except breast. So key takeaways, CAP publishes regular updates, so stay updated, and such webinars and workshops are very useful to keep ourselves abreast with the developments. And it is important to report HER2 in solid tumors according to the latest CAP updates. And this helps clinicians make an informed decision. So thank you very much for patient hearing. And I'm sure there will be a lot of questions at the end of the session. Thank you.
Madam, thank you very much for enlightening us on the updated guidelines of CAP reporting templates for HER2 testing across the different solid tumors. We will take the questions at the end of the webinar if time permits. Now we will move on to the next part of our webinar, which is a panel discussion. For the panel discussion, I would like to invite Dr. Ghansham Vishwas, who would be moderating the case-based panel discussion. Dr. Ghansham is an executive director, consultant medical oncologist at Sparsh Healthcare, Bhubaneswar, and he is a professor of medical oncology at some hospital, Bhubaneswar. Along with Dr. Ghansham, who is a moderator, we have our panelists. I would request Dr. Savitri Krishnamurthy, Dr. Sangeeta Desai Madam to join again. Dr. Sheikh Ali Barodawala, who is an head of surgical pathology from Metropolis Healthcare Limited, and Dr. Archana Lakshman, who is consultant pathologist from Apollo Hospitals, Chennai, to join as a panelist. Dr. Ghansham, over to you to take the discussion forward.
Thank you, Dr. Sushant. So good evening all. Thank you for this opportunity. And so let me straight away go to the cases. So So 3S, including our teacher, Dr. Sangeeta Desai, Dr. Savitri, Dr. Shaikali, and Dr. Archana. So I present a case of 60-year postmenopausal female, no significant comorbidities, and no positive family history of breast and ovarian cancer. So way back in March 2021, presented with cough, breathlessness, and a palpable right breast mass. Started initially as a right breast mass of 4 centimeter on a routine mammography with diffuse suspicious calcification in the upper outer quadrant extended by approximately 8 centimeter length. So routine blood test, X-rays, ultrasound were done, and then the physician ordered for a PET scan. We showed right breast mass with multiple right axillary lymphadenopathy, bilateral lung mets, and for which she was symptomatic as breathlessness and some mediastinal lymph nodes. So a true cut biopsy of the breast mass was done. We showed infiltrative duct carcinoma NOS grade 2, and it was on the basis of the PET scan and the biopsy report. It was a right metastatic breast cancer. So it was estrogen receptor positive. It was progesterone receptor positive. So in 2021, it was reported as HER2 negative, and Ki67 was 60%. So here I am the only medical oncologist. So considering that the HER2 test was interpreted, as we have heard from Dr. Sangeeta and Dr. Savitri, in a binary fashion and reported as HER2 negative in 2021, when the concept of low HER2 or the ultra low was not there. Would you consider this patient eligible for a targeted therapy? To make an informed treatment decision, which additional parameters would you look to be incorporated in the pathology report? So if I go back, so we have 2 targets in this report. So one is estrogen receptor and is the HER2 receptor. So since it was a estrogen receptor positive, so normally in a metastatic HER2, HR positive and HER2 negative, we ask for a baseline germline BRCA. They may or may not have a history of family, but we can, because even in a HR positive, 10% of the patients can have a germline BRCA mutated, which is higher in a triple negative. Second is HER2 here was negative. So on the basis of HER2 negative, definitely I cannot offer any targeted therapy on HER2. That was way back in 2021. So to make an informed treatment decision, which additional parameters would you like to be incorporated in the pathology report? So 2025, so there is a various other things that needs to be added, and Dr. Savitri and Dr. Sangeeta has already discussed, and again we are going to highlight on those issues. So to Dr. Archana, so suppose this report in 2021, so now if you try to extrapolate in 2025, so what other additional parameters you want to mention here?
I mean, calling scoring, giving a different score like 0, 1 plus, 2 plus, and 3 plus is mandatory. And as per the present guidelines, even dividing the 0 as 0 null and 0 plus with faint membrane staining is mandatory since drugs are available, sir.
Right, great. So now this patient, so if a medical oncologist is treating, so we have kept chemotherapy at bay for this type of patients. They may or may not have a visceral disease. So they are going to receive one of the CDK4/6 inhibitors. So this patient, ribociclib with an aromatase inhibitors was started. And we know that the median survival for this group of drugs is something around 2 years or so. And ribociclib, which stands out to be the superior among the 3. And so this patient went on to do well for 18 months or so, when she started having a bone metastasis and symptomatic of bone and the evaluation showed a bone metastasis. And you know that bone is a target for hormone receptor positive. The patient so he was BRCA negative. So PIK3 also was done, which was negative. So there was no PIK3 mutation. The patient continued on ribociclib beyond, because you can use the drug beyond progression, and then the injectable SERD was used, that was fulvestrant. But patient within next 60 days have a symptomatic progression in the liver. So this time, so initially started with a lung metastasis, then patient did well for 18 months, progressed on the bone, switched over to fulvestrant from letrozole, and this patient went on to progress after 60 days with a symptomatic and an imaging liver metastasis. Now, so he has a lung mets, for which he's not much symptomatic at this moment. She's symptomatic for bone mets, and there's a liver mets. So considering the previous HER2 negative report, would you base your treatment decisions on historical HER2 score, retesting and rescoring from the archival block, considering doing a fresh biopsy to retest and rescore HER2? And we have vividly discussed, and Dr. Archana rightly said that probably, so at that time, the point of reporting, so actually it should be 0, 1, 2, 3. So historical HER2 score. So now probably on that basis, you may not be able to start the treatment, retesting and rescoring. So yeah, so if at present, the patient is not keen for a biopsy, rebiopsy, or the biopsy is not possible for XYZ reason, so definitely we can get back the archival blocks and do the retesting and rescoring. So here is a question for Dr. Savitri. So 2021 and 2021, so 4 years have passed. So what is the challenge of doing a retesting and rescoring from the archival block?
So a couple of things I want to point out. First, I want to know what antibody was used in the archival specimen. So, if 4B5 was used, then I would pull that slide and reevaluate and see whether I can clearly this time give the information, whether it is like 0 null or 0 ultra low or it is 1+. So, but if at that time it was not 4B5 antibody, or I feel that, there were a lot of artifacts or it's not very optimal, then I may kind of recut another one from the archival block and try to stain with the 4B5 antibody following the current good strict protocols. If I think that should be doable, so doing a fresh biopsy at this point just to do HER2, in my opinion, is not needed.
Okay, great. So Dr. Saikhali, so what is your take on doing a rebiopsy? So do you typically rebiopsy a patient in such a setting? So how you are going back to your clinician and say that please do a rebiopsy if it is possible?
Yeah, so in this setting, as there are new lesions which are developed, there's a liver lesion which has been, found despite treatment. I would definitely advise, to go for a fresh biopsy and retest for HER2/neu. And at the same time, if the archival block is available, that also I would like to review to see whether there is a difference and is there any progression which has been found in the new metastatic site. So that would be my advice, because if there is a propensity that sometimes after treatment, as the cancer progresses, there might be a change in the results of even ER/PR and HER2 as well. So that is documented, not so in a great percentage of patients, but definitely we do get to see some variation in that result. So I would definitely go ahead and advise rebiopsy. Yeah.
Absolutely. So if an archival tissue is there in 2025, so you can go and rescore that. But it is always wise to have a rebiopsy, because there are new type of lesions, new onset. So if you see the ASCO-CAP guidelines 2015, the ESMO 2018 for a rebiopsy at recurrence, so rebiopsy to be done to assess the receptor at least once in the patient's cancer journey after the initial biopsy. So therapy to be based on the current receptor status in case of discordant between this primary and the metastatic. So there are global data available. So this is a 2015 paper. If you see estrogen, progesterone, and the HER2, so 10% variations are there. So this represents 1 out of 10 patients can have a significant number of meaningful therapy at this moment. So like if you see ER positive becoming a negative in around 5 to 10% patients, HER2 becoming from positive to negative in 5% and negative to positive in a 5%. So there is Indian data available in Annals of Oncology of 2018. So that shows a bit different. In short, if you see only a HER2, so there can be a negative to positive in more than 15%. So that means, and if you put together ER, so from negative to positive 10%. So in total, the discordance was driven by more negative to positive in Indian subset in this Annals of Oncology was published in 2018. So that means 1 out of 4 patients can go on into an additional treatment. So these are several factors that suggest the importance of retesting HER2 status in the metastatic setting. So we know that. So these are different situations where you can do that. So dynamic expression of HER2. So Sangeeta ma'am, so do you say that there is a dynamic expression of HER2? Yes or no?
100% yes.
Right, ma'am. So it is a spectrum. So dynamic expression of HER2. So if you see this paper of breast cancer, so evolution of low HER2 expression between early and advanced stage. So HER2 ISC score increased from primary to metastatic disease in a good number of patients. So HER2 low to HER2 zero evolution was observed in another 20% of the patients. So HER2 low expression is dynamic and may be enriched in the advanced stage setting. So this is how you can look like. So HER2 expression in breast cancer is dynamic, as madam also agreed, and also Dr. Savitri spoke in her. So this is HER2 ultra low prevalence in a historic ISC zero sample. So Sangeeta ma'am, so if you dig out the TMH last 10 years, so before this concept of HER2 and low and very low came into, so what is the expected probably change in the ISC zero status?
Actually, it is already documented in this particular paper that around 50% will be identified as HER2 ultra low if you rescore, because whenever it was done many years ago, the thing is that, see, there are two ways of looking at this. If the reporting pathologist had just written 0 and not qualified further, it's always better to write what you are seeing and then give the score. So for future review, it does help. So I think if we go back and dig out HER2 zero or HER2 negative, we will find almost 40 to 50% 0 plus.
That's a huge number.
Yes.
So there's a huge number for AstraZeneca to peep into, and because that makes this patient a therapeutic options for HER2 treatment.
Yes. Yes.
Thank you, ma'am. So is HER2 prevalence similar in regards to tumor location and sample collection type? Dr. Archana, so what is your take on this?
I mean, the pre-analytical factors does play a role, but sometimes we do find discrepancy between the metastatic setup site and the primary site, sir. We do see it's rare, but it's there.
Right. So as per the Destiny Breast 06 trial subset analysis, efficacy and HER2 prevalence is similar irrespective of tumor location and the sample collection time, but we do see different, as I also presented. So there are global paper, there are Indian data. At least some patients will be benefited with a different therapeutic treatment. So at least one IC report with discrete IC scores and percentage cell stain in required in the metastatic setting. So a fresh biopsy was ordered to reassess HER2 status in this case, because we know, so the lung was the site, the bone was the site, and the liver. So Dr. Saikali, so if these are the 3 sites, the patient is agreeing for a biopsy. So which one do you prefer? So is there a difference between the sites, lung versus, because in a triple negative, it is said that you should avoid doing a liver because the PDL1 is low. It's better to have a from the primary side. So what is your take on doing so bone versus lung versus liver?
I think in this case, it would be preferred to be done from the liver, I think, because again, it would be difficult to biopsy the bone. And again, lung biopsy is a little complicated procedure. So I think that would be more of a clinical call. And with regards to the patient condition, that would be should also be taken into consideration. But as far as these different sites are concerned, I don't envisage a huge difference in different metastatic sites. So I would prefer liver in this case because it's easily accessible, and that would be done without much complications. Yeah.
So easily accessible, and also this is the new metastatic site.
Yeah.
So,
Yeah.
so Dr. Savitri, so do you have a different take on this?
No, I entirely agree. So also I want to point out that currently we all do biopsy of the metastatic site, that is ASCO-CAP kind of recommendation. And bone is particularly a problem because, as you know, that doing immunostaining after decalcification of bone biopsy is a problem across all labs. So I entirely agree that liver is perhaps a more logical site to kind of biopsy in this case. But one thing is that for selecting a patient for targeted therapy with TDXT, presence of HER2 low or ultra low across any of the specimens is allowed. That means between the primary site or any of the metastatic sites, if there is a 0 ultra low thing, it is doable. So obviously, your original question is, if, say, for instance, the archival specimen you pulled out and you saw that it was low or ultra low, that is a big information for the oncologist that irrespective of the metastatic site, the patient will at least be eligible.
Right. But the problem is, madam, so if you pull out the old archival tissue and if you have documented, so there is HER2 1+, and if the patient is not affording for a TDXD, so the patient is not a candidate, because for other anti-HER2 agents, so it has to be HER2 3+ or a FISH positive.
That is true. So I entirely agree. Actually, this topic between primary and thing is very, very interesting because this year I got a San Antonio spotlight presentation. Guess what? On change in biomarkers after neoadjuvant chemotherapy in the primary tumor. So that topic is coming back. I think it is getting revisited because particularly of the HER2 changes that is happening after neoadjuvant chemotherapy, not in the metastatic site, but even in the primary tumor after neoadjuvant chemotherapy.
So now, so Destiny Breast 04 and 06 trials have used this antibody to detect HER2 low, ultra low breast cancer. However, labs in India also used other antibody clones. So will this impact the identification of HER2 low or HER2 ultra low breast cancer? So Dr. Archana?
Yes, definitely this will affect, sir, because this is the antibody which has been validated to detect that low level of expression, especially low and ultra low, for which the drug is available. So if we are using the other antibodies, the studies say that there is a very high risk of overcalling or undercalling. So if we are undercalling, then we are denying the patient of getting the treatment. So in an ideal setup, it is better to do it on a Roche 4B5 antibody on a platform, Roche platform.
Right. So just to make the whole audience understand, so what is Destiny Breast 04? So these were all in a breast metastatic setting. So the Breast 04, so which was NEGM 2022 publication, so it included HER2 low, so that is ISC 1+ versus ISC 2+, which was ISC negative, and these were all pre-treated with at least 1 to 2 prior lines of chemotherapy. So Breast 03, so which came in the later on in 2024 in the ASCO. So this included HER2 low and also HER2 ultra low. So that was the difference. So this was a chemotherapy naive setting. So here HER2 low was almost 700 odd patients. HER2 ultra low was 153 patients. Just to make you understand, so this is one of the philosophy I was presenting in one of the forums, and everybody will remember this Air India flight. So Destiny 04, which included HER2 low. So this lady in the picture was about to board that ill-fated flight. But because of the Ahmedabad rush, she could not reach the flight. So she had a ticket, which was a confirmed ticket, but she could not board because of the rush, and ultimately her life was saved. So what happened to the other gentleman where our Modi Sahab is there? So I consider it's a Destiny Breast 06, which is HER2 low and ultra low. So he had a confirmed ticket. He made into the flight when everybody died, including the pilots. So he was the only survivor on the window seat. So it means that if you are picking up an ultra low, somebody who did not have any expression, so at least the drug like TDXD will give this patient some survival. So that is how I put this Destiny Breast 04 and Destiny 06. So it's just a philosophy. So somebody probably can correlate or relate to the whole that mishap with the Air India that happened. So treating low and ultra low HER2 expression tumors, and we have heard this. So probably, and at this Sangeeta ma'am, so ultimately, so if you put the whole spectrum of HER2 3+, low, ultra low, so out of 100 patients today, so how many patients will not be a candidate for a drug like TDXD?
I think it is just HER2 0 or absolutely null. And
Right.
score 3, I mean, for score 3, there are many other, it's actionable target and there are many drugs available. So very few patients who with HER2 null kind of report, they will not be,
Right.
they
So
won't get
HER2,
any treatment.
yes, ma'am. So probably 20% today. So out of 100, 20% only may not be a candidate for the drug like TDXD. Otherwise, 80% of these patients will benefit with the drug like TDXD. So in the yesteryears, so only 20%. So out of 100, 20% would have been a HER2 3+, who would have benefited with the anti-HER2 agent. Today, the situation has reversed in 2025. So we are talking that only 20%, absolutely no staining. So that null. So these are only 20%. So who won't benefit with the, so this is what the change. So now 80% are getting benefited. And this slide again, Dr. Savitri and Dr. Sangeeta has shown. So Destiny Breast 04, which included HER2 low, 60% would benefit with the drug. And these are all HR positive setting. And the Destiny Breast 06 widened the horizon. It included ultra low. So making 80% patient benefit with the TDXD as compared to 60% in the Breast 04. So several labs in India use Ventana system for HER2 staining, but do not employ the locked staining protocol, which Madam Dr. Savitri has alluded to. Will this impact the identification of HER2 low or HER2 ultra low breast cancer? Dr. Saikhali, please.
Yes, I think if you're using the 4B5, which is a very good clone, and we must use the lock protocol for that because that is proven in the studies as well, and that will actually help you identify these faint stainings and localize them properly. So because any change in the incubation time, any change in the antigen retrieval times, which can be modifiable for other antibodies, that does not work in this setting. So for ultra low and low, one must use the lock protocol, and we can request the team to set the protocol for that and do the validation study as well. So that should be done for this catching this group of low and ultra low. Yeah.
Absolutely. So as you rightly said, so this is one of those, even Dr. Sangeeta Madam's colleague, Dr. Tanuja Seth and et al. So presented this poster
Yes.
where the impact of locked low HER2 protocol versus routine protocol on HER2 results was mentioned. So difference in staining pattern and intensity between IC0 and 1. So we have seen this again from both the speakers. So 10x versus 20x versus 40x, and what measures can be taken to negate the subjectivity into HER2 negative ultra low identification. Dr. Archana?
Probably, it should start with pre-analytical variables, reducing the cold ischemia time, and as such, and using a validated clone, validated platform, and using log protocol, and participating in EQUAS, IQUAS, and constant ongoing training for the pathology. So everything plays a role.
Right. So Sangeeta Madam, you want to add inter-observer consistency and diagnostic challenges?
Well, this has been adequately discussed during Dr. Savitri's talk. The thing is that it is the at the lower level of intensity, it is very important for the pathologist to go to the highest power. And in case of any problem, always consult a colleague and participate in external quality assurance scheme. And most important is using log protocols. So these are the various measures which can be used to ensure consistency. And of course, computational pathology is the answer to bring in more of uniformity standardization.
Thank you, ma'am. So now the differences in the staining pattern and intensity between IC0 and 1 plus are very subtle. What are the best practices pathology labs should follow to ensure accurate identification of HER2 ultra low breast cancer? So how important it is for the labs to have a computational pathology infrastructure to reduce subjectivity among pathologists with respect to HER2 ultra low breast cancer identification? Good to have, must have. So I think Dr. Archana and Sangeeta ma'am already allowed you to. So Dr. Saikali, if you want to add something to that extra. Oh, he's mute. Dr. Sheikhali, are you there?
Yeah, sorry, I was on mute. Sorry. So I totally agree with what Dr. Archana had said and Sangeeta ma'am had also put forth. And Savitri ma'am has alluded to this point in great detail. So definitely the pre-analytics are very, very critical. Actually, Sangeeta ma'am has been the crusader of fixation in the country as well. And that is also a very critical part for all the immunohistochemistry assays which are going to impact treatment. And definitely computational pathology now, as Madam said very nicely, Savitri ma'am, as augmented intelligence. So that should be used, and it is good to have in the laboratory setting. But there are inhibitory factors, as Madam already mentioned. So definitely these are upcoming things, and labs and pathologists should be ready to adopt to these practices in order to make patient care much better. Yeah.
Yeah, right. So currently the clinical practice guidelines such as ASCO, ESMO and NCCN, which every medical oncologist have to peep into and look into. So while prescribing, so do not endorse digital and computational pathology for clinical reporting. Would incorporating these technologies into clinical practice guidelines improve their adoption? So Sangeeta madam, so what is your take on this?
Well, I'm a big proponent of digital and computational pathology, and but the policymakers and administrators, they need to be sensitized on these aspects. And if this part gets included in the international guidelines, this will certainly help the pathologists to set up digital and computational pathology. That's what.
Absolutely. So now moving to other solid tumors. So now
Ghanshyam,
AstraZeneca. Yes, please.
Dr. Ghanshyam, sorry to interrupt, but you have another 5 minutes.
So I'll finish in 2 minutes. So,
Thank you.
so the other solid tumors, so FDA grants accelerated approval from many other solid tumors for HER2 positive. So Dr. Archana, so what is your just one line? So breast versus others. So what is your take and what is your message to the crowd today?
Yeah, as Sangeeta ma'am has already said, we all follow gastric protocol for anything other than breast tumors.
So Dr. Archana, last question. So these are all various tumors. So where you don't want to put your money into, so all these cancers, ovarian, endometrial, cervical, bladder, biliary tract, pancreatic, colorectal, lung. So HER2 testing. So one cancer, HER2 3 positive, FISH positive, but you may not expect a response. So what is that cancer?
Lung malignancy, sir. There we expect activating
the
mutation.
answer is pancreatic. So
yeah.
the response was 0. The answer was 0. So Sangeeta madam, you have anything to say on that?
Well, I just want to bring audience's attention to the fact that for some of this, for pan tumor trial, it is IHC immunohistochemistry result, and there is only one cancer where they have done 2+ with all the equivocal cases. They have gone ahead with FISH. But if referring to your next question about NGS, So NGS identifies amplification as well as mutation, but here in the trials, it is immunohistochemistry which has been used, and that we have to keep in mind.
Right. So this was the question. So Dr. Archana wanted to say no. So about lung cancer. So Dr. Savitri, so lung cancer, HER2 overexpression, HER2 mutations. So what is your take on that?
I think in our practice, routinely, I think, lung cancers have NGS testing, whether it is an EBUS FNA or whether it is a surgical specimen. So I think for lung, I would go ahead and do protein expression as well as molecular testing on the cases, which is what is done in my practice.
Right. So thank you. So these are ASCO guidelines. So these are ASMO guidelines. So that has brought and added HER2 low and ultra low situations. Even the NCCN 2025 shows that. So that last was the comprehensive notice. So power of pathology at home and clinic. So that was the last slide. So my wife is a pathologist. So we also trained under at TMH and also worked with and trained under Dr. Sangeeta and the clinic. So your pathology is the boss. So thank you so much for being a part of this panel, and over to the organizers. Thank you so much.
Thank you, Dr. Gansham, for moderating the session. Thank you and heartfelt gratitude to all the panelists who have participated in this case-based discussion. Now, as we conclude this webinar, let me invite Dr. Neeraj Arora, Secretary of Molecular Pathology Association of India, to give the concluding remarks and vote of thanks. Over to you, Neeraj, sir.
Yeah. So thank you so much, Sushant, for leading this webinar and the meeting today. I would like to thank the esteemed faculty, Dr. Gansham, Dr. Shakhali, Dr. Sangeeta ma'am, Dr. Archana, Dr. Savitri, for taking time out today and teaching us so much about HER2 new. There are a lot of takeaways for me as well. Learning about HER2 new low, ultra low, its role in a targeted therapy, the challenges associated with and how to overcome those challenges in the clinical practice so that is very important to know, because these are the things where we can benefit the patient. And following the learning about the newer things, Dr. Savitri, it is again an honor to have you here. And it is a coincidence that we started with you, and we are kind of ending this collaboration, this educational collaboration, which started, I think, 2 years back. This has been a 2 years culmination of a long-standing effort in that area. So it is great to have you again here, ma'am. We learned about the newer updates with respect to the lot of AI algorithm, augmented AI algorithms being available now. The computational pathology driving this area and continues to do so and improve the patient care here. And as we have already been sharing that pre-analytical needs to be addressed in many of these areas as well. So a lot of learnings here. So thank you so much, ma'am, and all the faculty for educating us in this area. We have, as I mentioned, we have had this association in this area since last 2 years, and I will just like to summarize some of those efforts uh, in this area. So we started in 2000. I'll just take 2 more minutes. It is not too much of a time that I'm going to take. So we started this collaboration with AstraZeneca as a part of our scientific dissemination of knowledge and education, which we all look forward to the various updates in 2024 with a local MDT. And this was driven by Dr. Geeta Shri, Dr. Mishra, and other esteemed faculty. And subsequently, there have been updates with respect to HER2 new. There was a whole website being created to be able to train the various pathologists. So this was very well appreciated. We had webinars, master class with the international faculty with Dr. Savitri and Dr. Nirmala, two great seminars and master classes. Then we also had two webinars on the NGS result interpretation, which is a gray area in this domain, and pre-analytical, which has been the culprit. Subsequently, we have had a series of webinars. There have been 9 webinars in total, touching upon HER2 new, PIK3CA, test failures in NGS, MET amplifications, HER2 new in pan cancers, and other areas. And I would like to thank Dr. Sushant and Dr. Vivek for leading these webinars. Without you both driving this, it would not have been possible to be able to disseminate. It is a lot of effort. I would also highlight here that there have been a lot of workshops being conducted, and again would like to thank Sangeeta ma'am for this effort. We have had 3 workshops already, and there are more in the pipeline. Ma'am has been traveling across the country, and she has been taking time out, training pathologists. There are a lot of positive feedbacks from this effort. Thank you so much, ma'am, for this effort. Without your continuous engagement, this would not have been possible here as well. Uh, and and just overall, so this 2 years collaboration, we have had number of faculties, almost 53 faculties have been involved in this educational dissemination. We have tried to touch upon the upcoming areas like HER2 new, PIK3CA, AKT, PTEN, ESR1, MET overexpression, TROP2. So this is an education not only for all the delegates, it is education for us as well, because we all pathologists are practicing pathologists. We need this effort to be able to guide our patients and clinical colleagues. So we have been able to engage more than 900 delegates. This is a huge effort, and this is the participations. And today also we have had more than 100 delegates have been able to benefit from this webinar today. So I would also like to thank AstraZeneca for this support, especially Shrikant and his team, and IAEO, without whose effort this webinar would not have been possible. All this effort has been, very well appreciated by a lot of people. We get a lot of positive feedbacks from across, and we have been able to publish some of this work. And I would like to share that publication as well. And this is available now. This publication on HER2. So whatever discussions we have had, whatever learnings we have had, have been tried to be incorporated into this publication. So this highlights the challenges and recommendations for identification of HER2 new low metastatic breast cancers in India. So this is available as a ready reckoner for all of our colleagues, for everyone to benefit from this. So this has been what we are kind of, as an organization, we are inclined, or we are working. I would also take this, special effort for Dr. Sangeeta ma'am for this workshops once again, ma'am. And I would request, if you want to share your experience, if you have some words for your experience, if you would like to.
Thank you, Dr. Neeraj. It has been truly gratifying for me to have contributed to shaping HER2 reporting practices across the country. And we have already had 3 workshops, and 3 are in the offing. And we have covered north, south, east, west. And as I said, this was all new knowledge that HER2 negative, which was few years ago completely undruggable, has suddenly become not only druggable but now unstoppable. And taking this new knowledge to our pathology fraternity, that was excellent. And it was wonderful to have this entire session in the form of a workshop, hands-on workshop. So a typical workshop is to be used to have or has, because tomorrow also I'm going to be in Jaipur conducting the workshop. The thing is that it's actually starts with 2 talks, and then there is a practical session. So basically, we are translating concepts into practical applications, and this is all teamwork. And would like to actually acknowledge Team AstraZeneca's contribution to this, especially Srikant, Bhavna, Himanshu, and a big thank you to Molecular Pathology Association of India under exemplary visionary leadership by Dr. Deepak Mishra, Dr. Neeraj, Sushant. They all of us and the delegates, the participants who have contributed to this workshop, because these workshops are actually very interactive. And so a big thank you to all of us. Thank you. And I hope these efforts continue. Thank you.
Thank you so much, ma'am, for those kind words. We have been missing our president, Dr. Mishra sir here. Unfortunately, he's not able to attend. He's been traveling to US. And so we continue our educational activities in 2026. So this was the last webinar. We meet again. So I invite you on behalf of MPI to the annual MPI Con 2026, which is going to be held at Tata Medical Center in end of February. So I invite you all for that learning there, and we continue our educational activities in 2026 as well. So thank you so much. And with this, we come to the end of this presentation. Thank you so much. Thanks.
On behalf of AstraZeneca, I really wholeheartedly thanks to you and Dr. Deepak sir, Dr. Sangeeta ma'am, Dr. Sushant, Dr. Vivek for like continuous support. It's not a one time. It's like continuous support day to day and end to end, sir. So without your support and guidance, it would have not possible. And heartfelt gratitude behalf of AstraZeneca to entire the people who are involved in this webinar and education session, sir. Thank you very much, sir.
Thank you.
Thank you, everyone. See you. Bye. Thank
Thank
you.
you very much. We close the webinar now. Thank you.
Thank you.
Sushant.